Colleagues, thanks very much for joining me. It's actually been a very busy time for HQIP, and we've got 5 really quite important reports have come out in recent months, and I'd like to take you through these. So if I could go firstly into the area of mental health, and we've got 2 reports here. The first on acute psychosis and the second on suicide. Suicide one is a confidential inquiry, and the acute psychosis is a national audit. Both have come in with very important findings, and suicide indeed has come in with quite a big coverage in the press. And what have we found with these? Firstly, the first-time psychosis is a relatively new guideline that's come in from NICE, and the Royal College of Psychiatrists, in particular the Centre for Quality Improvement, have done a HQIP audit to this. And I guess it's fair to say that the findings are fairly stark. So what the NICE guidance has produced are 8 standards, and the audit has reviewed in relation to these standards how we in the National Health Service are performing. And I'll just run through these, and the numbers are a bit stark. So the first standard was to do with allocation engagement, and it's to do with, in a sense, early treatment. Quite a few of these audits come in with something to do with early treatment. And indeed, in relation to the guidance produced by NICE, which is patients with their first episode of psychosis should really be being managed within 2 weeks of presentation. And what we found, what colleagues in psychiatry have found, was that 33% are being seen within 2 weeks. If we widen that on out into a much wider time scale, it does get better, so it gets up to 62%. Nevertheless, with this condition, and indeed several of the conditions that we're going to discuss in this review, early treatment really makes a big difference. And you can imagine somebody presenting with their first episode of psychosis. It must be dreadful for the patient, dreadful for the families. Really, one could understand getting early diagnosis and treatment, and yet we're only sitting at 33%. And so it goes on down. Cognitive behavioural therapy is the second standard. 41% of those patients were getting that in a timely period. Family intervention, I've already mentioned that for a family this must be a catastrophic affair. Suddenly a young person presents with acute psychosis. And the standard is that there should be contact with families. Only 30% or thereabouts of families are having contact and support. The medical therapy for the acute psychosis is clozapine. Again, not doing particularly well, with 36% being prescribed in a timely manner. Moving on down into physical health assessment. Obviously, physical health assessment and the management of physical health problems in this group of patients is really important. Not doing too well here. 22% only really getting a physical health assessment, and even worse in terms of interventions in physical health, 13%. Educational support, actually we've done much better with 50%. So overall you can see that NICE have crystallised the treatment, the management, etc. of first-time presentation with psychosis, and the psychiatrists have audited to that. And what my take on this is that we've got a long way to go in terms of helping, and there is help at hand. So the College of Psychiatrists have been asked by NHS England to develop a self-assessment tool and kind of packs to help colleagues in mental health implement these guidelines, and indeed actually implement the real management. So I would encourage you to read this audit as a really good national audit, highlighting a really important area of care, that is first-time presentation of psychosis, showing that there's a fair bit of work to do here, but the help is at hand insofar as that there is a helpful pack to help colleagues get on with this management. The second area in mental health is suicide. This actually, I'm just reading this myself, it's kind of a tragic affair, because this was suicide in young people under 20. And this comes in under the confidential inquiry banner done by the colleagues at the University of Manchester. So it was the University of Manchester National Confidential Inquiry into Suicide and Homicide. You may well have seen this in the newspapers. Again, it really, really makes stark reading, and I would encourage you to look at that to see their findings and see what we can all do to help. In terms of the results for this, an infographic has been produced by colleagues at the University of Manchester, and I want to come back to that in a second, but it is incredibly good at pulling forward into a single PDF document, one page, the findings from this. I'm just going to go through some of these because they really are heartrending in terms of these young people who commit suicide. Bullying, 22% have had some episode of bullying, 15% abuse or neglect. And I'm just picking out some areas that hit me. Academic pressures. Roughly half of all of these young people were in education. 15% were experiencing academic pressures, and indeed 27% the affair occurred in and around the time of the exam. I'll just pull this up here just whilst I bring the rest of these results up, because the kind of way it was broken down really does give a very good insight into what's been going on. 12% were noted to be searching on the internet for techniques for killing themselves, which really is stark, takes your breath away. Quite a percentage had physical health problems, and these weren't major illnesses. For instance, acne and asthma featured quite highly, which gives us an insight into how these conditions, which lined up against many of the conditions we treat in medicine, particularly acne, may not regard it as particularly big or important, but yet for these young people, obviously was incredibly important. They had about half of them had previous self-harm, so there were markers in the system in relation to these children and young adults. And indeed, I think it's 27% expressed suicidal thoughts in the week prior to their death. Again, could something have been done there? And they had been in contact with services indeed. In fact, 40% about had some contact with mental health services. So, and in fact, 30% with the police or youth justice. And then the final thing that came out from this was the kind of final event, the straw that broke the camel's back. And the thing that the reports picked up, and bearing in mind that the way these reports are done is they pick a body of young adults, children who have killed themselves, and review back through their history. And the things like relationship breakup and exam pressures, those kind of things come out. So really stark reading this, and it's a very big marker for all of us in healthcare and social care as to what could we be doing better in terms of these tragic, and it's not just these young people, but their families as well, catastrophic for all concerned. I would encourage you to read through this. The second thing, and this is a message really for all of us in the audit community, is to look at the infographic that's been produced. So we're so used to reading documents with 20, 50, 100 pages, which are a hard read, and in one page of a PDF, virtually everything has been summarised. And anybody who's any doubts as to how to produce an infographic, what would be better in an infographic, or who's wedded to putting numbers and tables, please look at the infographic in this. It's in the executive summary of this report. And there you'll see how to crystallise findings out from tables into something that's really easy and really makes a big impact. This is a national audit produced by the Royal Society of Rheumatology, and it's the report of the National Clinical Audit for Rheumatology and Early Inflammatory Arthritis. This has been done pretty tightly to a nice standard, and we'll go through that, but you'll see that actually it looks like we've got a lot of work to do here. And indeed, that kind of work is a lot to do with speed of presentation, diagnosis and treatment. So what's become apparent, and everybody in the inflammatory arthritis art community will know this, that the earlier diagnosis is made and treatment started, the better it is, both in short term but also in the long term. The audit pulls out, as its introduction, the kind of impact that long-term arthritis has on patients, families, and indeed the economy. And just to pull out one or two of those things, it's kind of stark as well. In terms of sickness, recording missing work because of sickness, it's estimated to cost 1.8 billion a year to the economy. So that's the financial burden. There's obviously the social burden, which obviously is dreadful. But just to actually highlight that social burden, 1/3 of sufferers will have stopped work within 2 years of onset of the illness, and half will be unable to work within 10 years. So if you actually translate that back, the earlier these conditions are jumped upon, diagnosed, treated, the better it is for the patients, and as a reflection on through into the wider economy. The results really hallmark these various bits to do with presentation, and you can read that. I'll just pull out one or two areas that hit me. And so in terms of presentation at the very, very beginning, bearing in mind that the standard is to get to see help within days, 25% of these patients are waiting over 20 weeks before they get to see, so to speak, the expert, and so on and so forth, so that very few are really hitting the standard. And then on the other side of actually the referral has gone in, so how long does it take to actually get to see the person who could make the diagnosis and make the difference? 1/4 of the patients are waiting 12 weeks plus, and that's basically, that kind of loses a huge amount of the benefit of all the benefit of early treatment and early use of agents. And there are now very important agents, biological agents, which can stop these diseases, stem them, and set the patients up for a much better prognosis in the short and long term. The report has done some review of availability and does show that we have shortages of rheumatologists, but also very importantly shows that we have shortage of specialist nurses, bearing in mind that specialist nurses will do an awful lot of the management, day-to-day management of these patients and their drugs. And the report does give important recommendations along the lines that we've been talking about. And there's an educational bit, educational for patients, just like we've had the educational campaigns to do with stroke. It's kind of to encourage patients to present early with an inflammatory arthritis, encourage our doctors to pass them on quickly, and then obviously help with getting services organised in our hospitals so that early treatment can be started, and bearing in mind that a lot of this is done by nurses, and training up and bringing nurses into the fore is really important here. So I'm hopeful that you'll read through this report and see how NICE produces standards, colleges do the reviews and audits as commissioned by ourselves, bringing out these really important reports so that we can direct therapy, help commissioners as to where our resources, our scarce resources should be going. I'd like to take you through two reports that have just recently come in to do with acute care in hospital, in particular surgical care. These are really, one is an audit, one is a confidential inquiry review. The first, the laparotomy audit, comes from the Royal College of Anaesthetists, the National Emergency Laparotomy Audit, NELA, looking at emergency bowel surgery. The other is confidential inquiry run by NCPOD, and that's into pancreatitis. Both come through with really quite interesting results and findings. And if I could go through the one to do with laparotomy, in particular emergency laparotomy, emergency bowel surgery. What it shows is, well, firstly, it shows pretty starkly the 30-day mortality for patients presenting with emergency bowel surgery is 11%. That's a pretty important number. Obviously, there's a spread, there's a risk algorithm depending on how, for particularly age and multimorbidity and things, how they influence that. But overall, there's 11% mortality. The audit showed important findings. Firstly, it showed, really importantly, that the variation across hospitals, that was not a factor, so that we were seeing expected variation, but that was to do with patient characteristics and the like. What it did show, however, was that there was important variation in delivery of care. And obviously variation is really important insofar as if we eliminate variation, we get better results. And if you can think we're starting off here with 11%, you could well argue that if we eliminate that variation, we'll start to bring that 11% down. And just to highlight some of the variation that was apparent, picked up by the audit. So a third of the patients presenting did not have a documented assessment of risk of death. Now, I think if all of us were to think about that, we would like to have some idea, us and our families, as to what we were getting into in terms of risk, bearing in mind that the risk on the other side of the coin without surgery is going to be very high. Nevertheless, I think it's good practice to document, especially when we have such a concrete number as 11%, that this is the risk. About 30% did not arrive at theatre within a reasonable time scale. The first iteration of the NELA audit looked a lot at the structure of care that's required to treat people with particularly for emergency laparotomy. And there are standards so that, for instance, there is an emergency theatre available 24/7, and indeed anaesthetists and surgeons. And if you think that this is picking up about 30% not arriving in theatre within the stipulated 2 hours, well, there's something to think about and work on there. About 40%, now that's a stark number, 40% were not taken to a critical care area after surgery. So just think about that. We've got 11% mortality in this group of patients. They have their emergency operation, and 40% are not going back to a high care area. Now, what that means is they're going back to a ward. That is definitely an area where variation should be worked upon and these patients taken to a high care area afterwards. And then a high percentage, bearing in mind there's a standard stating that those patients who are elderly, and a lot of these patients will be elderly, that their care should be joined, the surgeons should be joined by elderly care physicians. Well, the vast majority aren't, 90% indeed. So you can see just in those 4 areas there's work to be done to reduce variation, and I'm sure all of us would agree that if that work were done, we'd start to see 11% dropping right down. Obviously, the outputs from this audit are to tackle those areas of variation: timely access to operating theatres, critical care provision, and elderly physician availability and help. So I would again encourage you to read through this audit. Really well done audit into their own standards, developed through a structural review previously. And here we are, 11% with variation in care, and I'm quite certain all of us would agree those variations are dealt with, that 11% will drop. The other audit well, indeed it's not an audit, it's a confidential inquiry, which is into pancreatitis. This actually did gain some traction in the news. And actually the actions coming out of this pancreatitis review are actually relatively simple. And indeed, if implemented, it might well save a significant amount of money. So just to take you through that. So patients presenting with acute pancreatitis, and obviously there's a spread of illness from mild pancreatitis up to severe illness. As many of us in medicine and surgery will know, the commonest cause of pancreatitis is gallstones, indeed just sitting under 50%. About 20% during alcohol is implicated, and then there's a smallish percentage, 17%, where it's not clear. One of the really stark things is there's quite a high percentage of these patients picked up in this confidential inquiry review who had previously presented with pancreatitis. Indeed, it's 20%. And those patients, those 20% presenting, the vast majority were presenting with the same antecedent cause again. Calling into question, why wasn't somebody thinking about what to do about that the first time round? Very interestingly, the review picked up that 20% of patients were receiving inappropriate antibiotics. And we've all listened to the news. We all know that we're using too many antibiotics. So here is this review showing that 20% of patients presenting with acute pancreatitis are having inappropriate antibiotics. And then, so the diagnostic test here is an ultrasound looking for gallbladder problems, stones, and other things around the pancreas. 20% again, no reason was given for not doing an ultrasound test. That's pretty stark, really. There is a standard in relation to pancreatitis in the milder form that patients picked up with gallstones with milder pancreatitis should have gallbladder surgery on that admission or shortly thereafter. And indeed, that was not the case. I think it's 20% were not having that. And when the reviewers reviewed through this, there was a lot that they couldn't understand why they weren't having that surgery. Now, when we move from the gallbladder bit across to the alcohol bit, 80% of the hospitals, and this is obviously a review of the entire process of care of these patients with pancreatitis. So of those patients where alcohol was implicated, 80% of the hospitals said they had an alcohol liaison service, but indeed only half of the patients were ever getting to see it, bearing in mind that these patients then represent. So there is some work to do there. And the final area of this is to do with kind of management by radiological techniques and the like to drain complications of pancreatitis. And essentially it wasn't very good in terms of was there on-site radiological help to do this, either in the hospital itself or in a networked solution, a networked affair, that it wasn't well worked out. So it was kind of left down to individual choice as to whether or not maybe there'd be somebody available to do drainage, etc. So obviously the recommendations that have come forward from this confidential inquiry are really homing in big time on gallstones and their management, and so that if the gallstones are found and the pancreatitis is not severe, the operation should be done very quickly, or if it's a severe episode of pancreatitis, it should be done reasonably soon thereafter. And then there was obviously the alcohol thing I've mentioned, but also the bit to do with networking, to do with radiological techniques and the like for drainage, that there should be formal network arrangements so that any patient presenting with pancreatitis, wherever they present, that they should be able to have access one way or another to drainage or whatever if that is required. So again, I would encourage you to read through that. Again, a really good example of the NCPOD technique, that is a really important quality improvement tool in CPOD and the confidential inquiry technique, so that you have an index event like death after so-and-so, or like pancreatitis presentation. And you review back through a set of notes to see, against standards, are we achieving this? And here we get this kind of result, which is really powerful in terms of helping colleagues in acute care to say, actually, do you know what, we need to be doing better in terms of our management of these patients, in particular gallstones. Are we getting alcohol support? Are we getting radiology support? Thanks very much.